we will not be talking about sudden death risk. We're going to convert over to what we call heart failure and hypertrophic cardiomyopathy. And for those who may not know, that means essentially exertional dyspnea with or without chest pain. So it is one of the pathways that patients may evolve with this disease. Occasionally, they also then evolve into the end stage, but Jacopo has talked about that, and we will be talking about patients with preserved ejection fraction, for which this is the treatment algorithm that we have, 2012. It is at the onset of symptoms, initiation of drug treatment, which is beta blockers, verapamil, disopyramide, diuretics. Those are the drugs that are used, not all together, individually, usually, to control these symptoms of exertional dyspnea, basically. There was some conversation earlier in this meeting that we don't have enough drugs, and I couldn't agree with Jacopo anymore that this has been an area which has been difficult. And at any rate, when patients are no longer controlled by drug therapy, then there has to be consideration for intervention. The patient is a true non-obstructed patient, no gradient elicited with provocation physiologically or at rest, then we have much less to offer, basically. These patients may go into the end stage, these non-obstructive progressive symptoms, occasionally without the end stage and systolic dysfunction, but the only treatment at the end of all of that that's definitive is heart transplantation. So that's it remains a difficult group, fortunately not very large. But over here is where all the action is. In the presence of outflow tract obstruction, what's the best way to manage patients? That's basically what I'm going to be talking about this morning. There have been a number of modalities offered over the last 20, 30 years. It begins with the surgical septal myectomy, which is almost 50 years old. Newer approaches in the early 1990s, a craze for dual chamber pacing, which pretty much has evaporated, and then more recently the alcohol septal ablation I'll be talking about, of course, in some detail. This all comes down to outflow tract obstruction, systolic anterior motion of the mitral valve with mitral septal contact. That's really basically behind the treatment algorithms that we're going to address because obstruction counts. This is a study. Marron was the first author, and it involved the center here in Florence with Jacopo and Franco Cecchi, putting together a large group of patients to determine the relationship between the gradient at rest and progression to severe heart failure. So note, this doesn't have anything, again, to do with sudden death. It is progression of heart failure specifically. And as you can see, based on this relative risk, there's a great deal of difference in that endpoint, whether patients had obstruction or did not have obstruction under resting conditions. So obstruction counts, but I must point out that gradients are very common. They may not all count. I'm talking about the, in part, about the provocable gradients that we can elicit with exercise and the treadmill, bicycle. You can see here this other study, again, with the same collaborators, showing a large number of patients that have these gradients who didn't have or didn't have much of a gradient under resting conditions. Some of these patients develop severe symptoms and need some kind of septal reduction therapy that I'll be talking about. We don't know the natural history of many of these type of provoked gradients occurring in asymptomatic or mildly symptomatic patients, so that remains to be seen. But this is an obstructive disease primarily. When you think about it, about 70% of all patients will have obstruction under resting conditions or can have such provoked physiologically. It is only a third of the patients that have the true non-obstructive form in which the gradient is not part of the disease, no matter what you do. So all of this brings us to therapy, the surgical myectomy operation, which is, for those of you who don't know, removal of a small amount of septal myocardium from the upper part of the septum where the obstruction is, produced by the mitral valve. This is a classic operation, and this is the man that's responsible for it, Andrew G. Morrow, the National Institutes of Health. Really is the one who put this whole thing together. We're talking about many years ago, of course, in the 60s and 70s. And ironically, he himself a patient with obstructive hypertrophic cardiomyopathy. At any rate, we know a lot about the operation now that Dr. Morrow didn't know. And as I said, the experience now is approaching 50 years. We have very low operative mortality in our centers in North America, certainly, and perhaps elsewhere, less than 1%. It's become a safe operation if performed by surgeons who know the operation. This is, Dr. Jakob is sitting there, and he would be among those who know the operation. And in these centers, like Mayo Clinic, Cleveland Clinic, Toronto General, it's certainly at Mayo Clinic, it's been 12 years since anyone died in the postoperative period from surgical septal myectomy. So the idea that this is somehow a dangerous undertaking is a myth that is obsolete. What we do know is that these symptoms that I've been talking about of exertional dyspnea are relieved by elimination of the outflow tract gradient. When you eliminate the gradient, you normalize the pressures within the left ventricle. Patients immediately perceive that difference and often, or primarily, return to what would have to be described as New York Heart Association Class 1. So it's a very dramatic and sudden change by relieving mechanical obstruction to left ventricular outflow. This is therefore a reversible form of heart failure. A reversible form of heart failure because it is due to obstruction which can be relieved, starting in this discussion with surgical myectomy. Myectomy doesn't leave much behind. Complications are rare in terms of complete heart block, at least in the modern era, and there is no scarring of the septum that's a residual surgery. So in addition to relieving symptoms, we know, based on study, that actually there may be a survival benefit. This is the Mayo Clinic operative experience. And the patients, this is plotting total mortality, okay? Total mortality. The operated patients with myectomy fall on the line with the general population. They do not differ. In terms of total mortality, if you plotted cardiovascular mortality, the survival would be up in the mid 90% over this period of time. There's a comparison here with a non-randomized study design. In green is a group of patients who weren't operated on and had obstruction for a variety of reasons. You can see their total mortality is very different than the operated patients. So relief of symptoms, quality of life, benefit, and also now we can say, because surgery has been going on for so long, that there is a survival benefit associated with the relief of the gradient. All of this put together as a basis for consensus recommendations or decisions. Here's the 2003, Dr. Spirito is part of this, ACC, ESC, ACC. that placed surgery as the primary treatment option for these patients. And also, the more recent guidelines from ACC, American Heart, that placed surgery as the first consideration for patients with obstruction who were severely symptomatic and refractory to drug therapy. Sort of a general overall consensus from those groups. Now, HCM is a global disease. It's been reported from well over 50 countries. It pretty much seems like the same disease wherever it occurs. But when you draw this map about myectomy, you get a different appearance. The myectomy operation basically has almost died out in the continent and also in the UK over many years. It survives in only a few places, as far as I can tell. Now, I could be wrong about this, since I don't live in Europe, but as far as we can tell, there's the Thorax Center in Rotterdam performing myectomy. And then two centers in central northern Italy, Dr. Jacob operating in Florence area for years. And also, more recently, this is a report from Dr. Spirito's group, Dr. Ferrazzi operating in Bergamo, in Italy, showing the increase in number of myectomy operations and the good results. So maybe you could argue that myectomy is coming back a little bit in Europe. And of course, the operation is being performed in the UK as well now, but there are over 50 countries in Europe, and we're only talking about 3 when we're talking about myectomy, because the competing procedure that has attracted all this attention, which has created that disproportionality, is the surgical septal ablation, which I don't think I have to explain to anybody here. It's the introduction of alcohol in the first septal perforator to produce a infarct and reduce gradient. Thousands of patients now have had this procedure. Necessarily, the follow-up is shorter than for myectomy. That's by definition. There is benefit in terms of gradient and symptoms that I'll show you, but one of the concerns, of course, is the infarct, because these two procedures are not the same. The operation and the ablation are not identical. One produces, meaning the ablation, a transmural infarct, which is not small. It's generally, could be on average about 10% of the left ventricular mass. Okay, and confined to the septum, of course, would be somewhere about 25–30% sometimes. It's a large infarct. Over here, no infarct. Don't let anybody tell you that there's an intramyocardial scar produced by myectomy, because it's not the case. All right. It is not one of the complications of the surgery. Now, that infarct intuitively would suggest that it might be arrhythmogenic, and there is evidence for that, even if you just analyze what is written, what is in the literature in terms of life-threatening arrhythmias or sudden death that could be attributable to the scar itself short-term after the procedure, alcohol ablation. It could be 10% in the literature. We don't really know the exact percentage, I don't think. So there is a risk for ablation that does not exist for surgery because of the infarct. And this is has been emphasized repeatedly. This is a heterogeneous disease, morphologically, as well as clinically. And the ablation is confined to using the anatomy of the first septal perforator, whatever it is. So sometimes things happen. I mean, we see these patients that come back to us from somewhere else. Here's the ablation, I guess, was here, distal to the level of obstruction, which would be here at the tips of the mitral valve. So it'd be residual obstruction, residual symptoms. It is somewhat blind procedure compared to the direct visualization afforded by the operating surgeon. Then there are other anatomic features. We talked yesterday, I guess it was, about the long leaflets. Sometimes patients have long leaflets that can contribute to postoperative obstruction. You can see how that may be. I showed you some with MRI. Here's some echo images showing the same thing, long leaflets, even after you resect muscle. Can these leaflets then compensate and come back and contact the septum? And this has promoted some surgeons to recommend plication of the anterior mitral leaflet as well as the myectomy. It depends on the patient. There's other malformations of the mitral apparatus that would seem to be most amenable to direct visualization by the operating surgeon, produce what is now called an extended surgical myectomy. One of those is the anomalous papillary muscle insertion in the anterior mitral leaflet. I showed you MRI images yesterday, and here's what it actually looks like. If you take out that mitral valve, you can see the papillary muscle extends or attaches directly through embryologic development into the anterior mitral leaflet. There are no chordae tendineae. So this is a muscular mid-cavity form of obstruction that requires a extended surgical myectomy, I would think, for sure, and not introduction of alcohol in the first septal perforator, wherever that might be in a given patient. Now, there are plenty of data out there. I'm not prepared to dissect all the meta-analyses and all the various positions. Obviously, I'm taking a position that is pro-myectomy here, but there are data from individual institutions that seem to support that the effects of both procedures are not identical. Here's the Cleveland Clinic on resting gradient. Both procedures reduce gradient, okay? That's indisputable. But it would appear the myectomy does so more. Then effect on exercise capacity measured by peak oxygen consumption. This is from London, and suggests that the effect is beneficial for both procedures, but more so with surgery. This is a North American study from Canada, the Toronto group, showing that gradient reduction is greater with surgery, complications are less, and symptom reduction is more. These are single institution studies comparing. And then finally, the European study from the Thorax Center in Rotterdam, showing that there is a survival difference between myectomy and alcohol ablation, which is significant. These are all centers that have come forward to say that the procedures are not identical in terms of the end result. This is all taken together, resulted in 2003, again, with the ACC-ESC document saying that alcohol ablation is an alternative, but a selective one for patients who would not qualify or would refuse absolutely for surgery. So something for those patients, but not for all patients as a primary treatment. The same thing arose during the guidelines in 2011. Alcohol ablation is an alternative, but only selectively to myectomy patients. Nothing much changed in those 8 years as far as consensus documents. Now, that's not the real world. because there are a lot of ablations that are going on. I haven't bothered to update this slide for years, but even back when I did it, we had an estimate of about 3,000 cases over 45 years for myectomy in the world, and even at that time, after only 5 years of alcohol septal ablation popularity, there were already more ablations done, seemingly, in the world in 5 years than operations in 45 years. So we're talking about something around 30x in favor, 30-fold in favor of alcohol ablation, probably in the real world. Now, interestingly, taken as a fact, paradoxically, all this interest in obstruction and removing it and septal reduction did not kill the operation. Actually, based on these Mayo Clinic statistics, the number of operations, surgical myectomy, is actually increasing dramatically during the same time that there is this excessive exuberance over alcohol ablation. Now, it just means that more patients are being recognized. In a way, it's sort of advantageous to the patient population to have these debates, I guess. So surgery is still in the game, at least where I come from. Where do I come from? Well, you know, this, for anybody who might care, this is our experience in Minneapolis, just to show how different, perhaps, this issue of septal reduction, relief of obstruction would be handled in clinical practice. You know, with a lot of patients there, 15% turned out to be the number that were, for whom it was justified to recommend surgery. That would be New York Heart Association Class 3, obstruction, either at rest or with provocation of 50 millimeters or more. That's your operative patient. Pretty much everybody, I guess, agrees on that. So 15%, and we rarely find the need to take the alternative treatment, which would be alcohol septal ablation. So we're, unlike that 30x I was talking about, it's sort of flipped around, and you can practice hypertrophic cardiomyopathy, dare I say, at a high level, with a surgery to ablation ratio of 20x. Now, a few years ago, Jacopo and the rest of the group sat around and tried to answer the question of whether it would be possible to answer this question of surgery versus ablation with a randomized trial, because that's what all the interventional cardiologists were saying. Why don't you just do this trial? You'll find out the answer, which will probably be ablation. Well, it's not that we wouldn't want to test that hypothesis, but it's impossible. This disease doesn't work for that. You would need, based on this analysis, you would need to start with 34,000 hypertrophic cardiomyopathy patients to have enough power to compare enough patients at the end with either technique. And what would you be comparing them for? Because we already would concede that both procedures reduce obstruction, and then anything that reduces obstruction will reduce symptoms. So that's not really the case. It would be a survival benefit. Is there really any difference? And that's a long-term study requiring a lot of power and a lot of patients, and we're just never going to be able to do that. So without an exhaustive analysis of every single paper that has been written from every center about this experience that the center may have had with one or both of the procedures, I would just like to finish by going back to consensus recommendations. These are groups that look at all the data and presumably make recommendations for the practicing community based on the best available evidence. L, ACC, 2003, myectomy. ESC, 2003, myectomy. ACC, 2011, myectomy, and the American Heart Association, finally, myectomy. So that is the consensus recommendations in the form of guidelines, other expert formula. Whether or not it really translates to practice and the realities of the world, I cannot say. Thank you very much.
Barry, thank you for this. No, for this mission of protecting, patients from alcohol septal ablation that may be indicated in selected patients, but cannot be used in the great majority of patients for all of those reasons that you have shown here and through the years. But a question about myectomy. Do you think that selected patients with a gradient who are in functional class 2, meaning they feel well enough, some limitation, don't have severe symptoms, some of these patients may be candidates to myectomy they have a gradient. They have mild, they don't have severe symptoms. Let's say, to help you, they are young. Do you think, what else would you like them to have to decide that they can have a myectomy without waiting for them to be in functional class 3 with severe symptoms and possibly a dilated, very dilated left atrium?
Well, there's, this has been a matter of discussion, of course, with a low mortality rate at a few centers. You can start to contemplate more prophylactic relief of obstruction. It's true. Now, unfortunately, operative mortality is never zero. So for that occasional patient that would die because of your decision to have surgery, who might be quite alive and okay otherwise, even without some symptoms, would be, unsettling. So that's really the kind of emotional issue. We already have that situation in pediatric cardiology. The patients are never operated on at New York Class 3. They were operated on without symptoms, basically, because children are not allowed to have this kind of disability. And that is consistent with the way surgery operates in pediatric cardiology for any lesion. We operate on asymptomatic patients. We're not used to that because we started with class 3, and then the reduction to class 2 is an adjustment, which would be dependent on having a surgical center with virtually no operative mortality. Actually, there's no, all through these years, there's really no evidence that waiting, I'm not necessarily promoting waiting, I'm just saying there's no evidence for waiting that is deleterious to the patients. It turns out that patients can be very symptomatic for long periods of time due to obstruction. You relieve the obstruction, and the ventricle comes back, cardiac function comes back, because of a point you made earlier today, and that is that there is no scarring when there is obstruction. So it's one of the benefits that somehow is, turned out to be that probably has permitted these patients to be symptomatic for a long time because of obstruction and then become asymptomatic once the surgeon relieves the gradient.
But if I can continue briefly this dialogue, what worries clinicians and investigators is the left atrial dimension in these young patients to see this left atrium increase with time, and at a certain point with generating the high risk of developing atrial fibrillation. Then when that step has been reached, you can operate. It's different to operate the patient who has not developed yet atrial fibrillation, and the left atrium is not so large, and you are sure that you will guarantee a very favorable prognosis. In a patient who has dilated, the very dilated left atrial size, even if has mild symptoms, then you can ablate the atrial fibrillation during surgery, but the results remain doubtful. So that is the worry comes from the atrial fibrillation. You want to prevent atrial fibrillation. Don't you think that is a question that a variable that we should include in the decision to operate the patient?
Yeah, I think it's a reasonable point, and I think you should do it.
So I'm authorized.
Absolutely.
Okay, thank you very much. And
should we ask Dr. Jakob to comment?
Yeah,
the only real surgeon in the room, maybe?
Yeah,
I don't know.
It would be an honor if
the great Egyptian
Jakob
surgeon operating on many of these patients here in Italy
could give us here the microphone. Could you bring the microphone here? We need the microphone here.
We need it here. It's coming. It's coming.
Yeah, but
right.
you will have the question later.
Thank you, Barry. I think you said it all. But I just would say that there are areas which cause concern in terms of when we see asymptomatic patients with a gradient of 120 and an atrium which is starting to dilate. That's a real thing. And should we be doing a randomized trial, or there is a large number of these patients, and at what stage in the provocable gradients? You have somebody like Jacopo and Marty did showing that it is an obstructive disease, but you can provoke a gradient of 120, but patient has very mild symptoms, and a gradient at rest of 20. What do you do? So these areas are important. And coming to the randomized trial, which you beautifully showed, there is a subset of elderly patients with comorbidities. Should we be randomizing there? And we might get quick answers and not necessarily wait for a very long time to show that these patients can benefit from either procedure, because the patients are in their 70s or have renal failure or something. Should they be randomized? So I would like, I'm now throwing the ball back to you, saying what levels of gradients, and do you go by provocable, and do you always do physiologic, like you say, challenge, or you have people having a mile nitrite or something else?
Right. Okay, so those are really the, you managed to point out, all the remaining questions about all of this. As far as randomizing against ablation for subsets, I don't know whether it's necessary, because everybody knows at this point that both procedures reduce gradient. Maybe one more than the other, but the reduced gradient And anything that reduces gradient is going to reduce these heart failure symptoms. So the trial really is about survival. And if you're talking about patients who already have advanced age, this just doesn't going to work. It would be a survival-based trial. It would have to go on for many years, and would have to include the assembly, initially at least, of more patients than have been identified in the United States, let's say.
But that again happens in the valves. I mean, some of the elderly patients actually live longer because they selected themselves to be in that age group, and they go on.
Yeah.
And you can show a survival advantage much faster than starting in another cohort.
Right. Well, we have also an ethical issue. I mean, I do. I mean, I can't. The idea of a randomized trial came up many times, and I personally, I just can't tell patients that they have to have the ablation because they have been randomized to ablation, when I don't necessarily think that's the best thing for that patient. And
so you don't believe in equipoise. What about the gradients, provocable gradients?
Right. Well, first of all, there are patients, for sure, that go to surgery because of provocable gradients only. It's a subset. If the patient is symptomatic during exercise or activity, and you justify the connection between the activity, physical activity, and the gradient and the symptoms, that's what we do, and they become operative candidates. As I mentioned, what we need to do for the rest, I mean, those are the patients that become class 3 or for Paulo, late class 2. But for the asymptomatic, mildly symptomatic patients, we need to do a study to see what those patients are like over time after the ability to elicit those gradients. And we say physiologic because the old cath lab, mostly techniques of the 60s, which have survived all this time, really don't make a lot of sense. I mean, we're talking about patients' disability with exertion. What does that have to do with dobutamine, isoproterenol, post-PVC response? So that's why we've said exercise makes the most sense, and that's what we're doing. Thanks for the questions, for sure.
Time is very short, but you had the microphone before.
Yeah, just a brief comment. I have to stand up for Germany here, and surgical myectomy is still a gold standard, at least at the German Heart Center in Berlin. And as I'm a pediatric cardiologist, this is especially applied in children where septal ablation is not really favorable. So just one brief question. In children, what do you recommend in children? Shall we apply the general guidelines that are set out for adults? And like pressure gradient, because they are usually asymptomatic?
Right. That's clinical decision making. First of all children should have a myectomy. I mean, ablation has no role in that age group at all, I would think. To encumber someone at 15 with a transmural infarct would make a lot of sense to me. But that is going on, okay? It's happened. And, whether to operate for obstruction in asymptomatic children, I think that is not unreasonable because in pediatrics, that's the standard approach to the lesions. But this is a different operation. So it's not the closure of a VSD. Okay, so what I just said would would require having a surgeon that was familiar with, as good at doing the myectomy as he does closing a VSD at age 5. The problem is that person may not exist conveniently. But if that were the case, I think that you know, we do that. We usually operate on children with mild symptoms, is what it really comes down to. The class 2 that Paula was talking about.